Okay. So, good afternoon, everyone. I'm Bob Jane, and I'm a medical student at Stanford, and we are very excited to introduce our speaker, Dr. Thomas Maddox, whose career perfectly embodies the intersection of clinical expertise, innovation, leadership, and system level change that all of us aspire to. Dr. Maddox serves as Vice President of Digital Products and Innovation at BJC HealthCare and Washington University School of Medicine, where he leads a $14.5 million healthcare innovation lab with 62 clinicians, data scientists, product managers, and technologists. But his journey to this role is what makes his story so compelling for all of us. After earning his bachelor's in economics and history from Rice and his MD from Emory, Dr. Maddox took a fascinating path through health policy fellowships at the Kaiser Family Foundation and the Institute of Medicine before completing his cardiology training at Mount Sinai. He then spent over a decade in the VA system, ultimately becoming the national director overseeing cardiac care quality across all 78 VA cardiac catheter all 78 VA cardiac catheterization laboratories nationwide. Now, his innovation lab has developed groundbreaking solutions that are transforming patient care from AI-enabled models that identify high-risk patients before they deteriorate to remote monitoring programs that kept COVID-19 patients safely at home. Beyond his innovation work, he serves on the board of trustees for the American College of Cardiology, led the ACC's COVID-19 hub, and is a member of the National Academy of Medicine's Digital Health Action Collaborative. What I think you'll find most valuable here is learning from someone who, as mentioned, is able to merge deep clinical training with system thinking, innovation, leadership, and policy expertise. And for this format, Arnav, who is our other co-host, and myself will be guiding this discussion with Dr. Maddox. But certainly, at any point in the session, feel free to either raise your hand and we will call on you, or drop your question in the Zoom chat and we'll have Dr. Maddox answer that way. So once again, Dr. Maddox, thank you so much for being here. And I'd love to just maybe initially open up by asking you, kind of what led you to operating in this very interesting intersection of multiple different spaces, and is it something that you always knew you would end up doing, or it just more gradually evolved on its own over time?
Sure, and thank you so much for the invitation and the conversation. I was excited to learn about your group and some of the questions that y'all had on your mind. So certainly happy to share my experience. Maybe it'll be informative to one or more of you. But it's certainly been fun. I did not always know actually that I was going to be in medicine, let alone how I would have the career that I've had in medicine. And I think that's actually an important lesson, that you don't need to know it all at the outset for it to be really interesting and fun, but rather you just need to sort of stay open to things that are potentially interesting and pursue them based on where your curiosity takes you. So as you mentioned, I went to undergrad at Rice, and I was actually not a science major. I was an economics and history major, and was on track to do something maybe like law school or something in the business world, and got turned on to the idea of a career that would allow me to continually learn and have a connection to a purpose that could be really helpful to people. And with those ideas, and then finding that some of the aspects of the legal and business worlds were less interesting to me once I dug into them, I sort of reopened up the idea of more of a science path. Always had thought that science was, interesting, and sort of the hypothesis-driven mindset that scientists have was a really smart way to approach the world. But I also knew that just being in a laboratory of some sort wasn't as appealing, because I'm too extroverted, maybe annoyingly so. So I wanted to make sure that I was still involved with people in some way. And so that pretty quickly turned me on to medicine. So I went through the pre-med stuff you need, the MCATs, the application process, et cetera. Went through med school at Emory in Atlanta, and then did my internal medicine residency at UT Southwestern in Texas. And it was there that I really started to identify both a frustration and a curiosity about how healthcare was delivered, that the actual way that we see people in our clinics and hospitals and procedure suites and deliver the care that science suggests we should to optimize health was done in a really pretty archaic way. You know, I'm quite a bit older than y'all, and I was at the time I was sort of in the generation that was at the tail end of paper records. So in my training, up until like the last bits of my training, we were still pretty paper based. And so I remember in my resident clinic, I would get these enormous paper charts that were largely illegible, full of a lot of like information that was hard to locate, often incomplete. And I would need to sift through that and somehow take all that poorly organized information and aggregate it in a way that could help me make an intelligent decision about the patient in front of me. And often do that in a totally unrealistic time frame. Like I had like 10 minutes to take a look at that and then 20 minutes with the patient, all of which was like 1/10, 1/100th probably of what I needed to be able to do an effective job. So, you know, there were days where I'm like, this is for the birds. Like I'm out. I'm gonna go do something else. But on days where I was a little bit more emotionally balanced, I would sort of say, no, delivering healthcare is what I want to do. It's a really noble field. It always has been, always will be. But the way we're doing it is bonkers, and we need to change this. And maybe I need to figure out a way to help contribute to that change. And so that's what kind of launched the questions and the experiences that I've had about ways to improve that. And every experience and role that I've had over my career to date has been guided by that overarching principle. Is there something I can do with this group or with this role or with this effort that could help us improve the way we deliver care? So that's kind of how I got to where I am, just kind of thinking with that overall purpose statement and then evaluating an individual opportunity accordingly.
Yeah, that's really valuable context, Dr. Maddox. Thank you for that. One of our students had a great question. We see a lot of remote monitoring technologies being developed by startups, but you've been on the health system side trying to actually implement them. Can you please talk about the challenges of getting innovation from a startup incorporated into larger government-funded or nonprofit healthcare systems like the VA or BJC?
Sure. Yeah, no, this is a common challenge that many startups have. And you know, the role of startups is really important because that's just such a fertile bed for new ideas. And so it's always interesting and fun when we have either folks here at WashU or other people around the country who are really passionate about a way to improve care and go out and find some capital to help them sort of turn their idea into a reality. There is a well-known phenomenon of the sort of valley of death where you take your idea, maybe you get some early, a couple of series of funding, get some early traction, and then you go and you try to get yourself into a system of notable size, be it here at WashU and BJC in St. Louis, or the VA is a big kahuna because it's in a national system, or anything in between. And I don't know the stats, I'm positive it's north of 95% fail. And often it's because the resources and the timelines that are almost baked into how health systems acquire, integrate, and deploy technology outlast, frankly, anybody's runway of funding that you have in the startup world. And so you can, and I see this happen time and time again, you can literally bleed yourself to death from a capital point of view, trying to get in the door and integrated to some sort of revenue producing situation for your startup and for your product. It doesn't mean that there's not a role for startups. Again, I think that's where a lot of our really important ideas come from. And I'm not totally sure we would see as quick a development of those ideas or as high a quality of those ideas if we didn't have a robust startup system. But I do think that where I've seen people bridge that treacherous point in their development is they either get attached to a bigger company that just has the resources to support themselves, or they get, frankly, adopted by a health system who agrees to nurture them along. Maybe the startups are coming from some of their employees, or they have an internal sort of startup community that will give them some of the support that a big health system can with regulation, legal, technology integration, all that stuff. That just takes a long time, but health systems have annual budgets for that reason and long runways for that reason. So I think that's sort of the reality of startups in that space. The questioner sounded like they were specifically thinking about remote patient monitoring. You know, we are relatively new, you know, like I mentioned, we've only been on electronic health records consistently as a country, really for only the last 8 years. I mean, it's not even a real decade. When you think about the HITECH Act in 2008, that really was the lever that made everybody go to EHRs. And so it took, you know, it took roughly 10 years to get everybody up to speed. So say 2018, we were consistently north of 90% of health systems being on an electronic health record. Well, that's just the beginning. Like we now have just sort of transitioned the information we had in paper charts to EHRs, but it's still quite incomplete, and we still don't totally yet know how to use it. So our tech stacks are still getting mature, and we're talking about 8 years ago, right? So that's a relatively short period of time. We're still somewhat immature. And now you're asking us to think about, well, integrate a new technology, namely remote monitoring sensors, figure out how patients who often aren't that tech savvy are going to use those sensors to reliably provide high quality medical information back to the health system, make sure technically that all connects correctly, and then have the care teams organized in a way to receive that data, review it, and then reach back out to that patient and give them helpful guidance in how to improve their health. That all needs to be built from a process and technology point of view. I haven't even talked about the fact that there are huge data privacy and regulatory hoops you need to jump through to make sure you're not violating patient privacy. And none of it is paid for. None of it is paid for. We don't, I mean, the codes are starting to emerge, but I get paid every time I see you in the clinic. I submit a bill. I know exactly how to categorize that visit and what amount of dollars I'm going to get back. We don't have that for the kind of remote interaction that certainly makes sense, and you can see the potential for it to be helpful. But if you're not going to pay for it, it's just not going to get the priority. You just can't. We live in too low a margin environment to spend a ton of time on unreimbursed activities. So the technical immaturity, along with the almost primordial regulatory and reimbursement frameworks that are at play right now, have been real challenges for remote patient monitoring. In research studies, we do see its benefit. We've done a couple of projects here. We see its benefit for patients. So we are continually trying to advocate at the College of Cardiology, in the broader health system arena, American Hospital Association, for let's get the regulatory and reimbursement frameworks up to speed so that maybe 10 years from now, it is sort of standard that when you go to your doc, in addition to getting your prescriptions and your advice about exercising and eating well, that we also hand you your remote patient monitoring sensor pack so that you can go home, get dialed in digitally into our health system. And that just becomes how it works in terms of the way we provide care. But, you know, it's a big ocean liner to turn. So it's important to have that kind of perspective in mind.
Thank you, Dr. Maddox. I want to shift over to AI, where I'm based out of an SF. Last week, OpenAI obviously launched its newest model yet, GPT. 5, and at least according to them, it does outperform all of their other models on their own healthcare specific benchmark. We also saw a few weeks ago that OpenAI had released the initial results from an implementation study based out of Nairobi, where they saw that across more than 40,000 patient visits, the physicians who were using their AI model had more accuracy from a diagnostic and management standpoint relative to those who were not. So, with all of that in mind, what do you think is the next logical step from a large language model standpoint as it relates to its implementation in the healthcare system? And given that there's no specialized AI approval pathway by the FDA as of now, what do we need in order to actually have a cohesive regulatory framework to this end?
Wow, man, if I had the answer to that, I'd be in a different role. No, those are fantastic questions, and I think very germane to where we are in the seemingly exponential improvements we're seeing with large language models. It was interesting to see OpenAI's claim around improvements in health measures. That field of how we evaluate large language models broadly, but specifically in healthcare, is also in its infancy. A lot of the initial work in large language models was could it take tests similar to what we get tested on as docs, our board exams, et cetera, and do better. And now I think largely the agreement is it can't, or at least equivalently, if not better. I don't exactly know where everybody on this call is in their medical education journey, but if you haven't already, once you get done taking your step exams, I hate to break this to you, but you're not a doctor. You're a good test taker. And it's critical knowledge. It's a very necessary step, no pun intended, but it does not mean you're a doctor. You ain't done. In fact, you're just beginning. And so, what we're often wondering about is, can the large language model do as well or enhance a seasoned clinician? And we struggle in sort of defining and assessing seasoned clinicians even before AI arose. In fact, I would say our ongoing assessment structure that we have for physicians is pretty rudimentary. And it's hard to take that example and lay it out for a large language model to understand both how do you train it to do well, and then how do you evaluate if it actually is doing well. So I'll just offer that as sort of a philosophical starting point, that it's a fuzzy area even before AI came in. And so it's just going to be fuzzy on how we assess and regulate and do all that. In some ways, though, because we have these questions and we do need to integrate this technology, it may help us improve our methods for both AI and human assessment and training and ongoing skill improvement in being a solid clinician. So I'm actually somewhat optimistic that this will be a forcing function in that way. But what do I say now to patients? We are quite experienced in having our patients come to us with all sorts of Dr. Google research. And whenever somebody comes to me and say they have a new diagnosis of heart disease, they're like, oh, I went and looked at all these websites and learned all this. And so I'm excited to be engaged. So first of all, my first response to them is like, thank you. The fact that you are being so proactive and engaged in your health, that you're doing all this effort to go seek out information that makes sense to you, speaks wonders for how this is going to go. Because we know that engaged patients do a ton better than patients who are checked out or totally passive in their receipt or their engagement with the health system. The second question I have is like, where did you go on Dr. Google? Did you go to Reddit or did you go to Mayo Clinic's website? What are your sources? What are your references? And so in some ways, that's the question I also have for large language models. What are you being trained on? what is the information you're using and that your model weights have been trained on to generate the output that it's gonna provide. And so most of the large language model vendors, Google, OpenAI, Microsoft, all of them, will speak quite clearly to where they've trained that information and how they curate that information to ensure that it's reputable and that it's being used in the training aspects of their model in a way that helps separate the wheat from the chaff. And that if they have not taken that step, then I would have a lot of skepticism about the accuracy of the information that would come out and the hallucination rate, which are the two things we worry a lot about. We are starting to see that these companies have health divisions that are informing this. Actually, one of my prior classmates at Rice is now the chief health officer at Google, and he thinks a lot about this, about how do you pick and choose the information and then feed it into your models to help accordingly. So I think part of our job, and we're thinking about this at the College of Cardiology, is how do we decide what to advise our clinician community to use and how to use it so that we're giving reputable information to our patients to be able to do so. And then what are going to be the checks and the regulatory standards that the FDA and other regulatory bodies are going to need to have in place to actually demand from the tech vendors who are providing these models, show us the training data, show us your measures of accuracy and hallucination rate, and keep showing them to us on an ongoing basis. Because we all know that you're not one and done, just like you're not one and done being a doctor. Every year, hopefully, you're getting better. So let's have a periodic assessment of your skills and your knowledge, and we need to be asking that of our models as well. And then we can determine, here's the relative performance. It's worth, giving the seal of the College of Cardiology or the FDA or whatever to say this is reasonable. And it's always caveat emptor. Always check the output in partnership with your care team to make sure that it's making sense for you, it's based on accurate information. And I think the number of pieces that need to come together for all that to work is obviously a lot, and what we're all busy trying to figure out. But, at the end of the day, I think this is another way, potentially a better way, to get patients engaged in their health, to get them educated in language that they understand, but from a grade level health literacy point of view, as well as, frankly, their own native tongue, particularly if it's somebody where English is a second language, that could really, really be helpful. I'll say on the care side, our house staff, I've never seen uptake this fast of a tech tool like Open Evidence has been taken up, which is an example of a large language model trained. It's obviously more provider facing than patient facing, but it is amazing. And I've just been super impressed with both the output, but it is very clear where it's getting its information, and you can very quickly link to the source data. And I've just been consistently impressed with the quality and the user interface that I experienced there.
And I must, add, having spoken with many residents about this recently, I think something that Open Evidence did very well is that they were able to, have the entire software basically endorsed by both Nejm and JAMA. And so certainly from a marketing and, kind of a credence standpoint, they knew what might make doctors more interested in actually using it versus a model that otherwise makes up its own references and has various hallucinations. So I think that's an excellent point. I think Arnav had a question next.
Yeah, thank you for those insights. Those were amazing. Actually, Erica had a great question. Did you, Dr. Maddox, have formal training in terms of knowledge about technology design or related fields? And if so or not, how did you break into this field? How do you recommend undergraduates gain experience?
Yeah, great question. The short answer is no. And I'll explain how, and I'm not going to claim to be an expert now, but I will certainly share how I got the knowledge I do have from a technology point of view. Just going back in my history a little bit, I got through med school, was going through my training in internal medicine. and mentioned that I got passionate about this idea about care delivery improvement and redesign, et cetera. As I was talking to various mentors about how to act on that interest, several of them who were, academic physicians, research physicians based in an academic medical center, said, "Oh, well, you need to get trained in research methodology because you need to go into health services research, which is an aspect of research that studies, as the name implies, how care is organized and delivered and what outcomes does it provide with that structure and process." And so when I was doing my cardiology training, which was at Mount Sinai in New York, I also did a master's in epidemiology up at Harvard. I would just go up. They had a summer program, so I would go up in the summer to Boston and do that. And that was very helpful for the first chapter of my career, to have the analytic skills that come with that degree, epidemiology, design, biostatistical, mathematics and calculation, et cetera. And that enabled me to understand and conduct large data set research of different health systems and how they provide care. It also further taught me the scientific method, and being able to craft a well-designed hypothesis, design an experiment to prove or disprove that hypothesis, to run the analysis accordingly, and then interpret the results in context. And those skills are going to be helpful in all of these areas, be it technology, medicine, et cetera. So I'm very pleased with that investment of my time and money into that. Once I finished my time at Colorado and got recruited to start this innovation lab at WashU, as I came here and sort of realized that innovation means new ways of bringing digital tools into care delivery operations, I knew I needed to get up to speed on digital and operations. And so I needed to better understand the technology underpinning care delivery, but technology writ large, and care delivery operations like business. How do you run a business? And so I did two things that were really helpful. I'll do them in reverse order. So on the business side, it wasn't a full MBA, but it was a management training curriculum that our business school here at WashU offers, sort of an MBA light. And frankly, at this point in my career, I didn't need the whole MBA thing. I'd had enough experiences to know the basics of finance, et cetera. But I was able to pick and choose different courses that helped me fill in gaps that I needed around operations and various ways to think about that. On the technology side, I actually got kind of lucky. And early on in my arrival to WashU, befriended our chief information officer, who obviously was a technologist. He had come from manufacturing, joined our health system around the same time I did. And that friendship turned into a working relationship where he actually hired me into this vice president role. And I was a member of his senior leadership team. And I remember when he offered me the position, I said, you do know I'm a doctor and not an IT guy, right? And he's like, "Oh, I'm very aware." He said, "We don't have anybody on our team who knows medicine, but I do know that I can teach you technology, and I know our team can. We can't learn, or we don't want to go learn medicine. We want to use you as our shortcut to be thinking about this." So it became a nice bi-directional relationship where we each had something to offer the other in terms of getting us skilled in what we needed. So that was how I got educated there. I did then start to learn more about principles of informatics, and I actually am going to sit for the clinical informatics board this fall, because I find that going through a process of preparing for an exam like that and stepping through that does help kind of like cement the knowledge and make sure you have a good sort of framework of organizing information around a certain field. So I do think there's value in the didactics and some of the certification. But I will say to you and to everybody on the call, like, experience trumps didactics 20 times over. And so really just trying to find opportunities to go show up in areas where things you're interested in are going on, and be an engaged and curious and collaborative individual in those teams, you will learn a ton. And if you want to supplement it with some didactics, fantastic. But whether or not your path in is through technology training or scientific training or medical training or business training, all are viable paths. You just need to sort of know where you headed and what might you need to supplement that with. If you're going to be a technologist, how do you get to understand clinical context? If you're a business person, how do you understand technology? And then set yourself up with the people and the experiences who can supplement that training. Because there's not one degree that gives you all of that. You could go to school forever, but you don't have the time or money for that. And frankly, there's a better way to do it with experiences.
Thanks, Dr. Maddox. We have a question from Tarani, and apologies if I mispronounce the name. And they're wondering, what is one market gap in cardiovascular medicine that you believe maybe is somewhat neglected and could be transformed into a startup business model?
Good question. So one thing I think one thing that's helpful to think about in innovation in medicine is to think about what area of innovation are you interested in. And one way to organize that is, I would argue that there are three big areas of innovation in medicine, and this is true in cardiology. One is pharmaceuticals. So as we learn more in our basic science laboratories about the underlying molecular drivers of cardiac disease in whatever way, coronary disease, heart failure, arrhythmia, whatever it might be, we often learn that, oh, a problem in this particular molecular pathway is what's contributing to the issue, at least in part. Can we modify that, often with pharmaceutical, and then turn that into something that is safe and effective and that could ultimately be turned into a marketable drug? That's one area, pharmaceutical. The second is med tech devices. So a new pacemaker or a new stent or some other sort of procedure and or device that also does something helpful and in a safe way to improve somebody's cardiac health. That's a second area. And then the third area, which is where I am, is on the care delivery innovation side, and specifically digital health. And so are there ways of delivering care that can be supplemented by digital tools that can also help provide a better way of getting care, maybe help you be more persistent in the things you need to do to optimize your cardiac health? I think there are opportunities in all three, but the ways that you do it are quite different. Pharmaceutical innovation generally is done, maybe the initial idea is done in smaller startups in biotech, and there's a lot of really cool innovation that can happen there. That's a very viable path. The reality is that today we have a lot of big pharmaceutical houses, the Pfizers, the Mercks, et cetera, are going to be buying up those biotech startups when they have enough evidence that whatever they're working on as a startup point of view looks promising. And it's often more economically advantageous for Pfizer to not like underwrite the basic R&D, but basically offload that risk onto the startup. Then they pick or choose the winners and buy them up, and then ideally continue to develop them into something like an Ozempic or a Lipitor or something else that is clearly just going to be a core pharmaceutical need in cardiology. So biotech startup is one thing to go think about. On the med tech, it's somewhat similar, although a lot of that, I think, still basic R&D and startup stuff still tends to occur in the big shops like Johnson & Johnson or Edwards or some of these other areas. That's a little bit more on the engineering realm, around sort of the basics of materials science, electrical engineering, that sort of path. But there are startups, there is an ecosystem around there where people are considering novel ways to design and deploy procedures or devices stuff with cardiac disease. And then the third area which is where I'm most experienced, is care delivery. Something that's true in medicine in general, but specifically in cardiology, is we have problems in helping people both identify issues in cardiac disease and then persisting in doing the treatments that they need to optimize their cardiac health. And maybe I'll speak to the last one in more detail. So, if I see somebody who has coronary disease, maybe they had a heart attack. And part of the drivers for that is their cholesterol is too high, they had diabetes, and they're relatively sedentary. Part of the treatment plan I'm going to design for them includes a variety of pharmaceuticals to help with their diabetes control, a variety of pharmaceuticals to help with their cholesterol control. And then we know that, frankly, even more effective than any pill I can give you is that aerobic exercise in particular, done well and done enough, is unbelievably effective in reducing adverse cardiac outcomes. But if you think about it another way, what I'm basically asking you to do is to form a whole bunch of new habits at once. And there's nothing harder on this earth than forming new habits and sustaining them. And so, are there ways to design habit forming programs that are good habits to form and that engage some of what we know behind behavioral science to use various nudges and techniques, often which can be affected with or delivered through digital devices, that can help you stay on track with the changes in habits you need to develop for ongoing cardiac health? I think if there are ways to do that, that are effective, that would be incredibly interesting, not only to the patients, but to whoever is paying for their care. And so whether or not that's a commercial insurer through their employer, or if they're over 65 and being insured by Medicare or Medicare Advantage, which is now being delivered through these big commercial insurers, or if they're a vet and it's the VA program, whomever, or if it's self-pay. At the end of the day, if we can do things that in the long run will be cheaper for them, but deliver a better health outcome, you've got all the right players engaged in terms of getting to where you want to be and somebody willing to pay for that program because it's going to deliver that good outcome in a cost-effective way. So, if you're at the point where you're trying to consider ways to break into the startup world that's going to address a market gap, I've kind of given you 3 different corridors to think about, all of which have gaps. Cardiology is a wonderful place in terms of the degrees of the pharmaceuticals and procedures that we have. We're just scratching the surface of what we can do with care delivery innovation. But I think a lot of gaps are present in all 3 and could be fruitful areas of investment for folks on this call and beyond.
Thanks, Dr. Maddox. Zinnia, I think I saw your hand raised. Did you have a question for Dr. Maddox?
Yeah, I do have a quick one. Thanks, Dr. Maddox, for all your time today. Just a little bit of background about me. I'm a 17-year-old. I'm an incoming freshman at Harvard. I'm thinking of studying biophysics. And so this past summer, while I've had some time on my hands, I was thinking about a couple of ideas about building a startup, like building a tool specifically. And so while I was thinking about that, I also realized there's a plethora of labs and startups all around the world, some doing very similar things, some doing very different, like building different tools for similar applications. Now, my question for you is, how do you stay up to date with all the latest technology so that midway through one's pursuits, you don't actually end up recreating a wheel that someone just created?
Oh, good question. I think there's not one way. And I think you just have to continually be surveilling the market, which is kind of a vague answer, but I think kind of the correct one, of what is out there and what are people working on. It is true, and I don't know all of them, but it is true that there are communities of entrepreneurs in the various areas of innovation that are out there, certainly well beyond healthcare as well as in medicine. And so how can you get connected to those communities? You know, you'll be in, I don't know if you're already there, but if you're in the Boston area, there is a ton of entrepreneurial communities that meet up periodically or have various activities that sort of surface what people are working on. And I think the real value there is not so much some presentation that somebody will give at that gathering, but it's actually going to be the community that you build. Because I have found that really the intelligence that I get about what's going on, and in my case, what might be useful for us at WashU and BJC, comes from individual relationships that I have. I'm part of a network that is probably now 40 or 50. Not all physicians, in fact, not a majority of physicians, but people with some sort of innovation role in their health system around the country. And so often I'll hear from my colleague at Penn or somebody at Mayo or somebody at Common Spirit that, oh, I've been having this problem and I've heard about these new solutions or this group working on this. And that's how I'll hear about it. And, you know, it actually, I think, probably allows us to know about almost anything of value. We'll certainly miss some things, and there's no perfect method that gets you to 100%. But if you're busy working in your garage on the proverbial startup, and you're not dedicating some of your time to fostering that community, you're not going to have the best ideas because you alone, no one brain has all the ideas, right? So you need to spark that with other brains. And it will also just kind of give you that sensory system you need to both understand, well, who else might be working on this that either could be a competitor if you think that's a threat, or potentially a collaborator if it works for everybody involved. And I just think sometimes people neglect that if they're like, I'm just going to code the perfect solution and stay in my basement until it's done. I'm like, maybe you will, maybe. But we know by and large, the better path to success is building and maintaining those communities of fellow entrepreneurs. So from your point of view, depending on what tool you're talking about, you know, what are the communities that are working on similar types in a similar type of area, and how can you get to know and build the relationships with them? It also is a lot more fun. You don't have to do it alone. So, it's somewhat vague. I think it's the right answer, but I don't know if that's helpful. But those are my thoughts.
Great, thank you so much.
Sure.
Great. Thank you. Next up, I'd like to call on Parisa for her question.
Yes, thank you again, Dr. Maddox, for this really insightful discussion. Just as a bit of a background, I actually am a biomedical engineering major from Duke, and a lot of my passions do stem in health equity, but also its intersection with the role of AI. And one like really common occurring theme in a lot of even my tech-heavy projects and research I do at Duke is the problem of overfitting, and the fact that, as you mentioned earlier, sometimes, you know, what exactly is like the robustness of the training data, or is the training data so limited that the model generalizes really poorly on other types of patient demographics, patient populations as well? So I guess my question is, what are some systemic approaches and steps we can take to help improve the robustness of training data that's used in a lot of these predictive models from the get-go? What are some like systemic efforts we can help take, whether it's, for example, I know like all of us, they now do offer a lot more racial diversity in patient populations that we can analyze, but how can we go maybe a step further?
Yeah, no, a fantastic purpose or question and intent behind that question. Thank you. And even though you're a Dookie and my family's all Carolina, I will still answer your question. We won't talk basketball, but I think if I could maybe give the most succinct answer I would say for that is go advocate for access. And what I mean by that is you're right that we have populations that have been, you know, historically and systematically unable to get the resources they need to be able, we're talking about healthcare here, to get into the healthcare system. And that is sort of the absolutely essential step it takes to start contributing information about yourself and your health conditions and your needs into what ultimately becomes source training data, in this case for LLMs, but frankly for any of our models or data sets or registries. So one reason we can't see the patients that we don't see is because they can't get into our doors. And the reason you can't get into our doors, there's multiple reasons, but a foundational reason is that you lack the means to do so. You don't have the money and you don't have the insurance to get in the door. So how do we open up the door better? And is that, are we advocating for broader access? We've had a step backwards in terms of the number of people that can get insurance. So we got to correct that, right? And how do we do that and when? And even if you do that, there was still a subset of people that even though they have nominally, they have insurance, it's only going to cover like a part of our health system and sometimes parts of our health system that are not that well resourced. So if you've got the bare bones insurance and you can only go to a federally qualified healthcare center, you know, there's perfectly good people there and perfectly good care teams, but they're resource constrained, right? So they may not have the electronic health records to connect to everything or collecting the data in a way. You know, they may not have the processes in place that allow for everything you need to contribute to the information required for that kind of training. So access to high quality, well-resourced healthcare, I think, is what is needed. And so how do you do that? Part of it is advocate. You know, some of that's going to come through legislation and through both federal and state government. So how are you aware of and adding your voice to the need for that? And then the other thing is going to be sort of continued education and transparency, honestly, in how we do use the data. I think we're all aware of the egregious examples of misuse of information and misuse of people's willingness to contribute to medical research, Tuskegee being the, you know, sort of the biggest example, that has led to very appropriate skepticism and opting out of like, hell no, I'm not going to contribute to that information because you totally betrayed my trust. And so the you, and we are part of that you, because we're going to be in the healthcare system. We have to say, okay, well, how do we start to restore that trust and then provide the transparency to where you can always sort of rely, you can always see where that trust is and how we're being principled in delivering on the responsible and transparent use of the information to get an LLM that gives you accurate information or give us signals that, hey, this is an effective treatment for all different parts of our population, or there's a differential benefit. And so we need to think about it in differential ways. You know, we all are different individuals biologically. And so how can we best understand and tune the various treatments that we have towards whatever the biological need is and the underlying variety that exists there. So advocate for access, improve our transparency, I think are the foundational things that need to happen. And if you do that, our data sets improve, which then means we can feed those improved data sets into models that get trained better.
Thank you, Dr. Maddox. I think we have time for 2 more brief questions. Mihir, I saw your hand raised. You can speak.
Hello, Dr. Maddox. I'm a biomedical engineering student and I'm passionate about healthcare, AI, and policy. My question to you is that we have seen that AI tools can promote disparities if trained on biased data sets. So, in your opinion, like what policies can be implemented on an institutional level or federal level that can mitigate bias and promote things like bias audits or more transparent reporting before an AI system could deploy it at a larger scale in the healthcare industry?
Yeah, in some ways, it's a similar answer to what I just said, right? Because at the end of the day, models, I mean, all the AGI hype aside, models are just mirrors of us, right? And so if to take the example, if I'm only trained on one part of the human population, but accidentally believe that that thus then represents the entirety of the human population, I'm going to make mistakes or misattribute things if I'm working with somebody who's part of a different population than the training I've had. And so it means that we need to train our models and train our humans too on the breadth of the population that would come into their practice. And, you know, for a large language model, their practice is the world, because generally these tools are available to the world. So I think, much like we said, when you use open evidence, one beautiful thing about it is it gives you these footnotes where you can click through and see what was the source data that made that recommendation. It's also probably important to have a mechanism, I'm not sure how you design it, but some sort of way to do source tracing of like, well, what were the population characteristics that informed this recommendation for the treatment? And to be honest, this predated AI by a long shot. Like whenever we interpret a clinical trial, as you guys know, if you haven't already, the first thing in that paper is going to be a table 1. And the reason we publish that is we say, what was this population study? You can't study everybody in a single trial, of course, and you wouldn't want to. But, you know, look at the table and you say, okay, if it was done in the VA and it was primarily men, all right, important information for the men I'm going to treat. But if I'm going to treat a woman, we need to make sure that this cross correlates. Could be. There are plenty of things that are fairly similar, regardless of, in this case, your sex. But in other cases, there are big differences. And so if we're missing something in our evidence base, then we need to say, okay, how do we go get that evidence? Do we need to then like fund a trial that studies women with this condition? Or maybe it's a geographic difference. Like we haven't had any studies of people in China on this, or anybody in Africa, or anybody, pick a country. How can we start to go and get that information so that we collectively, human and AI alike, can know if that is truly something that we can apply to this group of individuals and have the benefit that we're hoping to have with any of our medical interventions. So it's an enormous ask. We'll never be done fulfilling that ask, but it is important as we're thinking about our roles in the healthcare system that we're aware of that need and we're advocating for it in whatever levers we have in front of us to advocate for that.
Great, thank you. We have time for one more brief question, so I'm going to call on Siddharth for this last one. Feel free to go ahead and ask your question, Siddharth.
Hi, Dr. Maddox. Thank you so much for your time. I feel like I've already learned a lot during this meeting. I'm a recent graduate from Pitt, and I recently got interested in the health innovation space, specifically in care delivery, and I'm just trying to find ways to contribute. And one of the thoughts I had is, first, like, do you collaborate with behavioral psychologists or behavioral economists in order to get a better understanding on how patients make decisions? And if so, do you work to implement these findings? Because I ask this question because a lot of the talk and the research is predominantly surrounding economic incentives, but many times it seems like these long-term savings aren't enough for patients to prioritize their health, specifically when creating new habits. I mean, we seek temporary like gratification, instant gratification. So like, you know, if a good paper, a well-done study with good methodology comes out on, hey, you can save 500, 600, $700 this year if you follow this steps, you come into your primary care physician. You know, sometimes maybe even if the data is there, we don't believe it, or we just don't care, right? So I guess I'm trying to understand the decision making behind the people and whether you've thought about that side of things and trying to make America healthier in general.
Yeah, no, wonderful thoughts. And absolutely, you're totally spot on. And I would say that, you know, the kind of analyses that suggest an economic benefit, like what you described, is appropriate if you're trying to pitch a program to a payer, right? Because now your incentives are in line. They're like, oh yeah, we need to insure this person, and we want to do it in the most cost-efficient way possible. So saying, okay, if they adhere to this medicine, they on average save $800 a year. That's quite motivating to the executive who would have to underwrite that program. But for you and me, we're like, oh, I'm not necessarily going to see that. That's an average, and that's a long ways away, and I'm busy. So we do think about that a lot. And, you know, you're actually in a state where a lot of work has been done, particularly at Penn. So Penn had one of the first nudge units in healthcare, where they thought, under the leadership of Mitesh Patel, who's now moved over to Ascension, but he has a lot of other collaborators who are continuing the work. They have thought a lot about what are the incentives and the habit forming techniques that we can leverage, that we all have as humans, to incent healthier behaviors, whatever that might be. And I think they've seen a lot of really interesting work, like triggering our collective aversion to loss. And so they've set up these lottery programs where if you skip your pill for one day or something, you miss an opportunity to be in a lottery for like $1 or something. But it turns out that people are like, get really motivated by that. Like, I don't want to miss it. And so they actually form this habit more rapidly than people outside of the program to continually be adherent to their medication. There's a lot of knowledge now about making your goals known to friends or family and having the peer pressure. We've actually engaged that technique in some of the innovations we've done with our nursing staff and sort of helping them do their day-to-day work, sort of setting up a friendly competition with their fellow nurses, making visible what their work is and how is it relative to each other. And it's driven some really impressive outcomes. So I do think we are newer to behavioral economics. Behavioral economics is not that old a field anyway. I forget when the Kahneman book came out. It's probably 2008. But, you know, that really sort of brought to focus, along with work from others, from Cass Sunstein and others, about how we all are sort of wired and how that drives our behavior. It's not necessarily rational, but it is predictable. And then how did we start to engage that in productive ways to help us deliver better health? You know, one place I look to be honest, is I look to the tech companies who I feel like use behavioral economics in totally nefarious ways. Like, it's one reason we're all addicted to our digital devices. But I do think we can take what they know and do so well and deploy them to, in my opinion, more noble ends of better health. So we think we work with some of the Penn guys, which is helpful. And then, you know, there's also a lot to learn from marketing. They know a lot about behavioral economics, again, often to just sell something. And even though I guess we're kind of selling health, I think we have a better product. So there's a lot of ways to pull that in. We're early on, but I would encourage you to look at the nudge unit, look at some information out there that it's more and more in healthcare. We're acknowledging and deploying these behavioral economic principles to improve. And I think companies that incorporate that in their products are definitely on the right track.
I'll definitely look into it. Thank you very much.
Yeah.
Excellent. Well, with that, we would like to start wrapping up. So I just once again wanted to issue a big thanks to Dr. Maddox. We have learned a lot in this event. I'm sure that many of us are walking away with insights around how might we actually take that interesting burning idea or thought that we have and work to launch or implement it in a way that actually moves and has impact both at the individual and system level. So once again, we deeply appreciate it and we look forward to hopefully engaging with you in the years ahead as well.
Absolutely. Well, no, the great questions. Carry them forward, guys. I mean, you know, I've been able to do some fun things in my career, but you know, the things that are going to happen tomorrow and in the years to come are on y'all's shoulders, which is a good responsibility. So, you know, take it seriously, and certainly, if I can be of any help, feel free to reach out. But I'll just be very excited to see where your collective talent takes you. So, thank you for the time.
Excellent. Thanks again, Dr. Maddox. Really, really appreciate it.
Of course. Have a great day, everybody.
Likewise. Take care.
Bye-bye.